Okay, everybody. Today we're talking about bioavailability and bioequivalence. So we're going to talk about bioequivalence now. And most of this is like definitions with a little bit of math. So why is bioequivalence important? Well, bioequivalence is really the way we determine if products are equivalent. So the bioequivalence is a pretty good hint to what it's talking about, is making sure that we have two products that are equivalent in what they do to the biology of the patient. So bioequivalence is making sure that we have compounds that are equivalent. And this is how we measure it. Bioavailability is usually what we're measuring to see if they're the same. So let's go over some definitions that you need to know as a pharmacist. So pharmaceutically or chemically equivalent compounds. This is where you have two or more compounds that have equal amounts. Oopsie. How do I want to write equal amounts pen equal amounts. Why am I not able to write? Well, I'm not able to write here, so that's all right. I don't, well, maybe in a minute we'll have to. Equal amounts of the same therapeutically active compound or ingredient. So it's got to be the same compound and it has to be equal amount and the same dosage form. So you can't have IV and PO or PO in a cream or even, liquid, like a syrup and a tablet. They've got to be the same dosage form, same active ingredient, and same amount. So it can't be a 10 milligram and a 20 milligram tablet either. They've got to be the exact same. So bioequivalence is when you have two or more of these pharmaceutically equivalent compounds that produce comparable. Now, notice the word comparable. I'm like, what comparable? It doesn't say equal, does it? It says comparable. So it's comparable bioavailability characteristics. So they're the same drug, equal amount, same dosage form that have comparable bioavailability when given in the same dosing regimen. So they have to, the way that comparable bioavailability is measured is looking at the area under the curve, the Cmax and the Tmax. I do have to draw here. Why won't it let me draw? Laser pointer? Can I do a laser pointer? Okay. Well, but I want to draw. Can I draw here? I don't know. And sorry. So we have our concentration time curve. And we give a drug. And we have a particular area under the curve. And so that's the area under this curve. Now it can stop at a certain point or it can go to infinity, or as I call it, the Buzz Lightyear amount, infinity and beyond. But those have to be comparable. I didn't say equivalent, I said comparable. The other two characteristics are the Cmax, which is the maximum concentration, and the time that occurs. So the Tmax, the time that the Cmax occurs. All three of these components have to be comparable in order for it to be considered bioequivalent. So what does comparable mean? Well, comparable means, I guess that worked. Comparable means that you have to be 90% confident. 90% confidence. So you have to have 90% confidence intervals. And what that means is that we're 90% sure that this is the truth lies here. And that is determined by your data and how reproducible and good precise your data is. But we're 90% confident that the area under the curve, Cmax and Tmax, all are between 80 and 125% of the reference drug. So this is for generics, for example. If you have a generic compound that's the same therapeutically active drug, equal amount, identical dosage form, in order for it to be considered bioequivalent, it has to have comparable bioavailability in between 80 and 125% of the reference drug. Area under the curve, Cmax and Tmax. Okay? Do you find that surprising? I did when I first learned that. That's a pretty wide range, isn't it? Between 80 and 125%. Now, this definition I expect you to memorize. You have to memorize this definition. You need to know what are the three things that determine if it's bioavailability comparable, what's the range, and what is a pharmaceutically equivalent or chemically equivalent product. Well, it's the same therapeutically active ingredient, identical dosage form, and in equal amounts. Okay? Now, what are pharmaceutical alternatives? So these are our alternatives. They are not equivalents, but alternatives. So this is when it's the same therapeutic moiety or the same drug, but they differ in their salt or ester form. So you can't give a hydrochloride, like a propranolol hydrochloride and propranolol acetate. Those are not equivalent. They may be pharmaceutical alternatives. Different dosage forms, different strengths. So these are all pharmaceutical alternatives because we can use them as alternatives, but they're not equivalents. And first, pharmaceutical alternatives are not interchangeable. You can't give a different salt or ester of a drug without a new prescription to a patient, or a different dosage form or a different strength without a prescription. These are alternatives, but not equivalents, and therefore you cannot make this change without a new prescription. Therapeutic equivalence is when you have two chemically or pharmaceutically equivalent products that produce the same efficacy and or toxicity in the same individuals when administered in the identical dosage regimen. So we give two different pharmacologically and pharmaceutically equivalent drugs to the same person in the same dosage form and get the same results, therapeutic results. Those are called therapeutic equivalents. Those also you cannot necessarily, well, if they're chemically and pharmaceutically equivalent, you can interchange them, as long as they're bioequivalent too. Biosimilar, this is becoming more important as we have drug shortages. This is a biologic medical product, which is almost an identical copy of an original product that's made by another company. And this is from the Affordable Care Act. Well, what do you mean almost? Almost an identical copy. What does that mean? Well, it means when there's no clinically meaningful differences in terms of safety or effectiveness to the reference product. There can only be minor differences in clinically inactive components, and that's when we allow a biosimilar. That is considered a biosimilar. An interchangeable biological project is biosimilar to an FDA-approved reference product and meets additional standards for interchangeability. An interchangeable biological project may be substituted for a reference product without the intervention of a healthcare provider who prescribed the reference product. So now we're going to talk about bioavailability. Bioavailability is how we measure bioequivalence, right? We have to have comparable area under the curve, Cmax and Tmax, to determine bioavailability. Remember, absolute bioavailability is the fraction of drug that's given that makes it to the systemic circulation. Absolute bioavailability is when you compare a different route of administration to another. So two different formulations, two different forms, so you're comparing them. Absolute is when you compare it to the IV. Remember, given something intravenously, you're giving the drug right into the systemic circulation. Therefore, that's the gold standard. That an IV has a bioavailability of 1 by definition, doesn't it? Bioavailability is going to range between 0 and 1. It's a fraction of drug that we give that makes it to the systemic circulation. So we're going to always compare it to the IV. The IV will always be in the denominator when we're comparing the bioavailability to another route or route of administration. I taught for a whole semester in Ohio, and the students didn't know what I was saying when I said route, because where I grew up, we say ROUTE, route, like Route 5 or Route 75. No, here they say route, which I didn't even know until the whole semester, and they're like, what are you talking about? So we're talking about an ROUTE. So through the years, some I've had some wonderful students that are native Spanish speakers, and they say I should say rauta. And sometimes I say route, because that's another way of pronouncing that word. So if I say rauta, route, route, or route, it all means the route of administration or route of administration. Anyway, back to this. So we're going to put the gold standard is IV, so we're going to put that always in the denominator. And the area of the curve divided by the dose, we're going to compare that, because really to get the bioavailability, we're going to compare area of the curve, right? We're going to compare area under the curve of something given other than vascularly. So this could be any other way, whether we give it sublingual, oral, on the skin, any other route. We measure the area of the curve for that other route, and make sure we reference it to the dose. Obviously, if you give double the oral dose that you give the IV, you're going to expect to have double the area of the curve. So we have to correct for whatever the dose is. Okay, so this is how we figure out absolute bioavailability. I'm not going to go through all this. I just show you how you're going to then get to relative bioavailability. So I do want to talk about this. The area of the curve from 0 to infinity can be calculated using bioavailable dose over clearance. Notice it's very close to our CSS average equation, which is a bioavailable dose rate over clearance. You can see the difference here is this is area under the curve, this is CSS average, this is dose, and this is dose rate. Well, dose rate is really equal to dose divided by tau, isn't it? It's really dose milligrams per time, or amount per time, or maybe milligrams per hour, or milligrams per day, or grams per day. But this is about dose divided by tau, isn't it? And CSS average is equal to area of the curve divided by tau. So you can see they're really the same equation, or similar equations, okay? So if we use this equation, and the dependent variable here is area of the curve. But if we rearrange it to solve for clearance, we know that product A and product B, if it's the same drug in the same patient, these clearances are going to be equal. So we can set these two equal to each other. And when we do that, then we can solve for the relative bioavailability of the first product to the second product. So this doesn't have to be an IV. This can be comparing two different generic formulations. This can be comparing a syrup to a tablet, etc. So this is our relative bioavailability equation. Okay, so we would put the area of the curve of our first formulation. Is this right? I have to go back. Okay, so that's that. And then we're going to do some problems using these bioequivalence concepts. Thank you. Bye.